Bismillahirrahmanirrahim. My name is Professor Tahir Sagir. I welcome all over Pakistan cath labs from NICVD Karachi for the first live case from Pakistan Society of Intervention Cardiology platform. From this year, we have started this activity of live transmission on monthly basis. Every second week of the month, we'll be doing a live case from major centers of Pakistan. Today we are doing a case of mitral commissurotomy. My team will be led by Dr. Navedullah Khan Sahab, Dr. Khalid Naseeb and Dr. Jahangir Ali Shah will assist him along with our senior intervention fellow Dr. Qasim Khan. My technician team is led by Mohammad Naeem with Raufin Riaz, Ammar and Imran Ali. We have a echo backup by our senior associate professor from echo department, Dr. Sumaya Gormani, and his technician Samina Naz. With this introduction, we have a panel of experts that includes Professor Ahmed Noman from PSIC Lahore, Professor Tariq Abbas from MIC, and Dr. Major General Nasir Samoor from FIC Pindi. We would like to start the case. I would like request Dr. Jahangir Ali Shah to please describe the case.
Thank you, Dr. Tahir Sagir. Please show me the slide. So I welcome you from here from NICVD Karachi. So today we have a very interesting case. Patient is 26-year-old male. He is a known case of rheumatic heart disease, and his symptoms are worsening from last 2 months. His function class shortness of breath, that is function class 3. His BMI is 21.6. His height is 161 centimeter. Weight is 55. Clinical examination, there is a diastolic murmur and all. ECG shows sinus rhythm with RV strain, RVH pattern. So you can see we did the transthoracic echocardiogram that shows the dilated left atrium, ejection fraction is preserved, and dilated RV with TEPC is 22. Mitral valve is thickened leaflet, doming of the anterior mitral leaflet and fixed PML, and the valve area is 0.7 centimeter on the transthoracic echo, and his Wilkin score was calculated is 8. His gradient across the mitral valve, the peak gradient was 35 and the mean gradient was 22, and the pulmonary artery systolic pressure was 95 millimeter Hg. So we did the fluoroscopy, there is no any calcification, and we did the T to rule out the LA thrombus and the MR. I can show you the next, please. Show you the ECG, you can see. Next slide. This is the ECG and X-ray. Next. This is the fluoroscopy we do routinely doing fluoroscopy before the procedure in RAO and the lateral view. There is no any calcification seen in this fluoro. Next. And these are the images of transthoracic echo and the transesophageal echo. In the upper left, you can see the parasternal long axis is doming of the anterior mitral leaflet and fixed posterior ML. And this is the second view. You can see the short axis in which the fish mouth appearance of the mitral valve. There the shifting of the ventricular septum and RV is dilated. We did the color. There's only minimum MR seen on the transthoracic echo. These are the T images. There's no any LA appendage thrombus and no any MR. And in the last, you can see the 3D images. You can see a very beautiful mitral valve is clearly seen with there's a small orifice in between. So this is the see, I hand over the mic to Dr. Navidullah Khan for the procedure.
Abdullah Khan will just introduce the inventory that is to be used in this case with the NOA balloon technique. Dr. Navidullah Khan.
Okay, can you hear me?
Ji, okay.
You can hear me. Okay, what we are going to do is that, can we come to this area? So I think that we will be discussing steps as we will have a slideshow before we we will have some. Okay, let's start with the stuff. So in this issue, we will be first we'll take a 3532 wire. We have a wire there. This wire will go to the SVC, and on this wire we will be taking the Mullen sheet in. The Mullen sheet will go with the dilator, and after this one we'll take out this wire, and after this wire we will be taking in this broken burr needle. The length of the broken burr needle is slightly longer than this dilator. So this thing will help us in puncturing the septum. For septal puncture, we will have some slides so that we can, before the procedure, we can give our fellows idea about that, how to, what are the things which we are looking in when we are puncturing the septum. Once we have punctured the septum, then the role of this PTMC wire, this is a pigtail shape PTMC wire, and this wire is a softer wire, which is this one, and this wire will be residing inside the LA, and the whole system will go on this wire. Once the wire is there, then the next step will be the dilatation of the septum. The conventional dilator is 14 French dilator, but we can use, if the septum is thick, sometimes we may need to use a 18 French dilator. There are different techniques of dilating septum, but most commonly this dilator is used. And after this one, we will be going for this NOA balloon. We will be discussing few steps about the preparation and parts of the NOA balloon. This NOA balloon, basically it has got, this is the balloon part. I hope you can see this one. This is the balloon part which is covered, and this is the balloon. And here we have got three hubs. One hub is just for the ventilation. This is the vent port, and this vent port is used for the flushing of this balloon. And usually we take a normal saline, and when it's easier, nothing more complex, you attach your saline with this one and flush it. Open the other side and flush it until you see, first you will see some bubbles coming out. And once you see no bubbles coming out and this is clear, just lock the system. The system is air free, nothing is special. Similarly, the central hub, this is for the wire and for the straightener. Now this is an important part, because this balloon is a soft balloon. In order to cross through the skin and through the septum, this balloon needs some support. For this support, we have got this straightener. And this straightener will be supporting balloon during when we are taking it through the skin and once we are crossing to the septum. After this one, the roll of the septum, and once we are coming out, then this one. The next part of this balloon is this golden hub. This is the silver hub. Usually we are used to call this silver hub and golden hub, but this is basically the true terminology, right terminology for it. This is straightener, and this one is stretching tube. The role of the stretching tube is that once you close it, the balloon will be in a stretch position, because what we want is that when we are crossing through the septum and we are coming back through the septum, the balloon should be in a stretch position. If the balloon is not in a stretch position, can you please release it? यहाँ से release करें इसको silver, इसको golden को. If you pull it out through the septum in this position, it may cause kind of a septostomy. So that's why once we are coming out, this is important that when you are crossing the septum, the balloon should be stretched. And when you are bringing it back after the completing the procedure, the balloon should be in a stretch position. So these are the parts of the balloon. Now, next thing is that we will be discussing a few slides about the septal puncture, so that before we go for the procedure, we will have some idea about that what are the things which we are going to do. Because we may not be able to stop during the procedure and telling the steps. So we will be looking at some of the slides. Please start my slides. This one, PTMC workshop. Next one. Niche, yeah, this one. Yes, please can you go to the full screen? Okay, so I want to see the slides. Yes, please. Okay, so next. Okay, can we go to this full screen? Yes, please. Okay, I hope you can see the slides. So just go forward. Next slide, please. Next. So this is basically a fluoroscopic view. We need to know, because once we are puncturing the septum, we need to know what is the fluoroscopic anatomy of the heart before we proceed for anything. Because our understanding of the heart is quite different, but the fluoroscopic anatomy is quite different. So when we see heart on fluoroscopy, this is the frontal view of the heart. As we are looking at on fluoroscopy heart, when we see RV and LV on our left side, and basically what we are seeing is our interatrial septum from the front, because we have got RA at the front and LA, left atrium, at the back. So when we see this septum from the front, we can see this fossa ovalis, and in this fossa ovalis, just below to this is coronary sinus, and then we have tricuspid valve. And in this fossa ovalis, what you see 1, 2, 3, 4, 5, these are different locations where you want to puncture the septum, and this position will be different because we know that the septal puncture, the purpose of the septal puncture may be different. You may be doing a septal puncture for LA occlusal device. You may be doing a septal puncture for PTMC with multi-track balloon, and you may be doing with a PTMC with the NOA balloon. Similarly, your purpose may be to puncture for mitra clip. So that's why you have different. Because you may have different locations for the septal puncture. Next, please. Can we go full screen, or this is the one we need to know? Okay, so in this one, this is the fluoroscopic anatomy of the LA. So once we go, we'll take the wire from IVC into SVC, and this is the position in the LA. And our aim for NOA balloon is to puncture higher and posterior, as high as possible, as posterior as possible, because the distance between the puncture and the mitral valve, we need, as we have seen, NOA balloon needs some space to work. So in our case, we'll be trying to puncture as high as possible and as posterior as possible. But for example, if you are doing septal puncture for multi-track balloon, your purpose will be to puncture as low as possible and as anterior as possible, because it will be easier to cross your wire from lower puncture directly into the mitral valve. Next, please. I'm just skipping this slide. And this is just for the juniors to understand what is the fluoroscopic anatomy of the heart. Can you please run this slide? Please run this one. Yes, please. So in this one, we just deliberately injected through the LA so that we can see what we see in our heart and where is the LA. You can see the appendage up there, and this is the whole LA, and you can see that LA, the mitral valve is just below the balloon. So this is just for the juniors to understand that how does our LA, we don't see LA because we don't see injections, but we can understand because once we were junior, we used to, our seniors used to say, ab abhi appendage mein ho, abhi isme ho. So we used to say, inko kaise pata chal gaya. But this is the thing, if you see these kind of images, you will have this kind of understanding. Next, please. Next, please. Next. And this is the anatomy once you see because we will be puncturing septum in the lateral view. So how does the septum look like in the lateral view? Next, please. I'll just go directly to a slide. Next, please. You can see this was the case with the calcified LA. So you can see, you can have an imagination of the LA, that where is the LA once you see in your heart. Next, please. Next. I'll go directly to a slide we have just done with this one. Next. So this will be the needle positioning. When we will be puncturing, we will be using the terminology of 3 o'clock, 4 o'clock, 5 o'clock. So what do we mean by 3 o'clock? 3 o'clock is that when your needle pointer is directing towards patient's left shoulder. So that will be a 3 o'clock. And once you go towards the leg, you rotate downwards, you will go 4 o'clock, 5 o'clock, 6 o'clock. So our puncturing site will be somewhere around 5 or 6 o'clock. Next, please. Next. I will be doing these steps. Next, please. I just want to show you 1 or 2 slides, then we will come to the patient and go directly for the procedure. Next, please. Next. Next, please. Next one. Yes, this one. So this is the CT angio view of the heart. So if you puncture, once you take the needle in, the needle direction will be at 3 o'clock. But if you puncture at 3 o'clock, you may go directly into aorta. And once you rotate about 4 o'clock, 5 o'clock, 6 o'clock, you will be directing your needle towards the septum. So this is a very important slide. Next, please. So this is the site where you want to puncture. Next, please. So I think, and next one. Next, please. And once you are puncturing in the lateral view, you would like to puncture, you take the distance between pigtail and the spine, and we usually try to puncture in the middle 1/3 of the part. Next, please. This is a very important slide. Please run this one. This septum was stained during the procedure. So we picked this picture so that we can understand that how does this septum, this LA look in the lateral view. So this septum has got a vertical part and this one is the horizontal part. If your needle is in the vertical part, you may dissect it. That's what happened in this case. We probably punctured into the vertical part, gave the dye, dissected, then took it out, reintroduced from the bottom, and then went through the horizontal part. So this is the thing we need to understand before we go for the septal puncture. Next, I think we just go for the live case now. So in this one, we have already taken they have done most of my job. In this one, I think, can you show us this? वहाँ नहीं आ रहा है, उनको नहीं आ रहा होगा लाइव. So conventionally, especially once if your senior is standing on your right side, you should do everything on fluoroscopy. नीचे दिखाओ please. So what we have done already, we have introduced a pigtail, and this pigtail is resting in the aorta on ऊपर दिखाओ, on the non-coronary cusp. So we make sure the position of the pigtail by pushing it down, rotate it and push it down. This is, you want to go to the lowest portion of the aorta. So pigtail is resting on the left cusp and your Mullen sheet is resting in SVC. Can you show at the top? Upar. So this is too far. We'll bring it down. Okay. Now we take the needle, broken burr needle in, and this one should always be done under fluoroscopy. The needle goes in. The direction of needle is at 3 o'clock. Can you show them my hand? So needle goes in, and one important thing is the distance between your needle and the distal end of the dilator. The distance should not be very close and should not be very far. So this is an important point we will be discussing in complication part, that this has got some complications with us. So we need to be careful. The distance should not be very close and should not be very high, because sometimes a junior person is doing and they are afraid of taking the needle further away. They take a larger distance between the two, and that's why they have some problems. So we'll go down. Now the important thing is, can you please center the heart? Thoda sa niche karo. Yes. Now the important thing is that what are your aims of puncturing? If your aim of puncturing is, this one is dropping into aorta, so I need to rotate. If your aim of puncture is to puncture higher, usually we stop near to the level of the aorta, here. And if you want to puncture lower, we usually go down and take at least one vertebral disc below the level of the pigtail. So what is your suggestion? Okay. Okay. So I think that we will try to puncture higher. We'll stop here and we'll go to the lateral position. Center karo. Please take. Okay. So if I puncture here directly, I'll go into the aorta. So my aim will be, just for the fellows, please center, niche dikhao. Table up karo. Yes, please. Thoda sa center karo. Thoda dai deng. So in this one, just for this one, you see, if I puncture here, I'll go into the aorta. So what I am doing is, I'll try to pull back and rotate 4, 5. Dai dijiye please. We'll see. You can see the septum. Capture karo. You can see the septum now. So, but this will be very close to the mitral valve. So I'll try to pull back and rotate 4, 5 o'clock. Die please. Yes, this one. So we can see the septum. ठीक है sir इधर? So there are different ways. Die please. Yes, some of the people, they try to stain the septum and then puncture. So we'll puncture here, and then the most important thing is take a cine here. So we are in LA and my cursor is directing towards 5 o'clock. So we'll introduce further so that our needle, and now I hold the needle and take the dilator and things forward. Now I hold the dilator and take the sheet forward. If you want to confirm that we are in LA or not, you can still give some dye. So we are there, and then we rotate again to 3 o'clock. And now our working will be in RO view. Next please. RO. And this is the point where you want to give heparin. Center, please. Sorry. Usually when you push your system, it tends to reside into appendage. So we need to be careful because appendage is a frail part. Now we'll flush it and take the LA pressure. As we know that our patient has a PA pressure of 80-90.
Prior to puncturing, we did also the LV angiogram that show no evidence of any MR.
Heparin 3000 given.
Simultaneous pressure कर दो.
वो वेव फॉर्म वेरी कर रहे हैं.
नहीं, LV में डालो.
Okay. So we'll take the simultaneous pressure and take the gradients. So we can see the nice gradient between the two. The EDP is around 5, the mean pressure is around 20. So you have got more than 15 gradient. So we pull back. And now the second thing will be heparin de diya.
Yes, sir. 3000.
Now we'll take the PTMC wire in. सेंटर कर देंगे प्लीज. Okay, so now wire is in the LA. And we'll take this balance sheet out. And the next step will be पेशेंट के हाथ सीधे करें. ब्लेड प्लीज कट. पेशेंट के हाथ नीचे होगा. The next step will be dilatation of the septum. Sometimes you are not sure that we are in LA or we are in RA. The conventional teaching is that you can go into iliocranial. Can you please go to the iliocranial? And this one will confirm because iliocranial is our 4-chamber view on echo. So you can clearly see we are resting in LA. And can you please come back? And then please hold wire. Now we'll dilate the septum. Usually what we do that we try to dilate the septum and feel the septum. If you can, because this in rheumatic fever you can have thickened septum and you may have resistance on the septum. So you try to dilate it until you don't get any resistance. You can see my hands, and on this one you need to hold your wire and bring the dilator down and then to take it forward. So in this way, you will not lose your position. The next thing will be you take out this dilator. Balloon discuss kar liya. So we have already prepared our balloon. The important thing is that when you take the balloon in, you always measure it with the caliber. So that your target balloon, we all know that this patient has got height of 160 centimeter. So that makes him eligible for a 26 balloon. So our practice at NICVD is that we don't stretch this balloon, this valve directly. We usually dilate it. If the size is 26, we dilate it with 24 size, keep it a little less size, and then make it 26 in the second dilatation. So now we have got this size of 24. Once you cross the septum, you take this straightener out because we don't need any support anymore, and we will roll the system on the balloon, on the wire, and then we take this stretching tube also out, and this is the working position of the balloon. Now the system will, the wire will come out, it does not need any support, and the function of this stellate will be there. The function of the stellate is not to make it go inside the LV. It will remain in LA. It will just direct our system towards the mitral valve. Now my balloon tip is in the appendage. So I need to bring it down gently, slightly pull forward. It will drop towards the mitral valve. And this kind of bobbing movement is that we are very near to the mitral valve. Once you are very near to the mitral valve, slightly rotate anti-clock and try to slide it inside the LV. Capture please. Once you are inside the LV, half inflate the balloon and then take the stellate out so that balloon is in normal functioning position. If anybody is not sure that we have in LA or we are in RV, sometimes you flip system into this one, you can just connect, just hold down, nothing to panic, pressures are there. If it is bobbing inside LV, no issues, rhythm is okay. You can connect it with the pressure and confirm that we are in LA, LV or in RV. Now the next step will be, we'll pull back till we'll feel some resistance and then inflate full. Full inflate please. The balloon is slipping down. So I'll inflate, yes, inflate now. Yes, please. This is the waist. Please, please, please. Down, please. As we know that we have already taken it to a 24 size, the die is less. That's why it's not giving full pressure. But this will give us some relief because the area was 0.5. The technique of not losing your balloon is that once your balloon is fully inflated, the first operator should push it forward so that once you deflate it, the balloon does not come back into LA. So you will not have to cross it again and again. Now again, balloon is half inflated, we'll pull back and now inflate full. Full, 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 full. Yes, oh. This is something which is, can you please capture it? The last click is sometimes, it is considered a bit dangerous because it is, in our experience, this sometimes indicates that you have cleft the valve. We can confirm it by looking at the pressures. No more This one, no more inflations. Echo, please. Like. Wire, please. Wire. Wire, please. So our job is done. No more inflations required. थोड़ा वायर पीछे करें. वायर आगे. Yes, please. ले लें सर, उससे ले लेंगे. बैलेंस शीट डाल देंगे. Again, the closing is first the silver part, that is straightener, and then goes in the stretching tube. ऑक्सीजन लगाई.
और इन टाइम है तो आप 5 मिनट कॉम्प्लिकेशन हो रहा है तब तक ये को कर देंगे.
Okay, so now we will be looking at the pressures, and we'll take the Mullen sheet again in. Oxygen लगवा दें पेशेंट. Out balloon now. So meanwhile we are looking at the pressures. I think that we have got few minutes, and we will be discussing some of the slides for the complications. LA प्रेशर दिखाओ. Okay, I think that at that we'll take the opportunity of this one. We are doing echo, and we are looking at the pressures. So I think you can see the waveform there.
Almost no gradient.
Okay, and we'll try to look at the RV pressure now. Our initial pressures were around 90. So I'll pull back the Mullen sheet, and if you can see on fluoroscopy, we'll just bring it down till it flips. Once it flips, yes, we are in RA, and we can push forward and see the RV pressure. So RV pressure has dropped from 85 to 50. So these are the immediate results, and we are not usually looking for this much thing, but this is the thing which we usually see, that the patient gets immediate relief. So EDP has not increased. The EDP is still around 510. So there is no MR and echo. Dr. Sumaya says everything looks good. So she'll be showing us some of the images of echo. These are the post-procedure images. So once we are done with these echo images, we will have few slides about the complication of this procedure. Okay. Okay. So they say that we are sending our images, while meanwhile we'll be looking at some of the slides of complications. Can you please start the slideshow? This complication part is important one. We need to understand that the usual teaching, usual saying about the complication is that if you have not done enough complications, you have not done enough cases. So it's not important that you don't have complications, but important thing is that how to manage them, and you need to be prepared for the complications. Next slide, please, and just go to the next. So these are the things which we have already discussed during the procedure. Next, please. Next. Just go ahead of 10 slides. 10 slide आगे चले जाएं. These things we have already discussed during the procedure. Next. Yes. So complications. Next, please. One important thing which we see, can we come to the full screen, or this is the maximum we can get? So the important thing is, yes, good. So the important thing is sometimes you can have a floppy septum. So that makes you understand that why we say that if you stain the septum, you will know that where is your septum, and if you have got a floppy septum, this will try to tent with your needle. And once the septum is tenting, it will go very close to the posterior wall or superior wall. So once you have punctured, if you have got a floppy septum, usual saying is, conventional teaching or bookish teaching is that you go under T guidance. But in Pakistan, we all know that we are all used to do these things under fluoroscopy. So what we do is that we stain the septum, and just after the puncturing, we give the dye. Can you run this slide, please? Allah. Yes.
10 minutes.
Okay. So, so this is an important thing you need to understand. You need to see the distance so that you will know that how further I can take my needle in. You have got this floppy septum. Next, please. Now, that's we have already seen that if you have punctured into the vertical part, you may dissect the septum. Usually, it does not cause any complication. It's usually self-healing. You don't need to be afraid of. But if you have gone into the vertical septum, you can bring it down, take the needle again, redirect your needle, and puncture to the horizontal part. Next, please. Next, please. Yes. This is an important thing you need to understand. That sometimes, once you have punctured, you may have, and when you give the dye, these few slides, they will tell us importance of giving dye and taking this angiographic image or cine image. Once you give this dye, and you see something weird. You don't see this dye flushing into the and just washing away. You see this dye is staining there. So this was a needle puncture. So if you have punctured LA just with your needle and you have not introduced further, एक slide पीछे जाओ. The dye will stain into the pericardium. You can still bring it down. Next, please. Next, please. Next, please. And redirect your needle. If you have only introduced your needle, the needle puncture are most of the time are self-healing, may cause some effusion. Can you go next, please? In this patient, please run this slide. In this patient, you can see the dye is staining into the pericardium. But the procedure, the operator directed the needle again into the LA, completed the procedure, and there was no complications. Next, please. Next, please. Run this slide, please. So you can see dye staining into the pericardium, but the procedure was completed successfully because it was just a needle puncture. Next, please. Next. Run this slide. Again, you see something weird. The needle direction is abnormal. The dye is not washing. But unfortunately, next please. The operator had already introduced the dilator in and the sheet in. And once you go into the RA, you found out that there is something really wrong. Next, please. And you confirmed it that your dilator is now into the pericardium. Again, in this one, don't get panic. Just stitch the sheet there. Some of the people suggest device closure, but I think in our circumstances, you can just simply go in and leave it there and shift the patient for the surgery. That's what we did in this patient. But there are options of closing this one with the device. Next, please. Next. I think this will be probably the last one because we have got a lot of slides with the complications. Next, please. What is this? You punctured, you gave dye, and you found out that you have done a coronary angiogram. So हमारे यहाँ कहते हैं कि इसका टोकन दोबारा बनवाना पड़ेगा, ये तो एनजीओ भी किया आपने साथ में. तो इसमें, so in this one, you don't need to make another token and you don't need to panic. Again, if you have just punctured with the needle, withdraw it and you can still complete your procedure.
Okay.
Okay.
Thank you, Dr. Navidullah sir, for comprehensive basics followed by a clean procedure and an excellent results. Some talk about the complication. As you see that the patient was having a area of 0.7, now it has increased to 1.6. The PA pressure was 90 at 85, 90 at the start, that down to 50 millimeter of mercury. Now I would like to ask our panel of expert, Dr. Ahmed Noman, can you give your experience or any question? Dr. Ahmed Noman.
Yes, panelist.
We can't hear you.
A very complex procedure, but you have done it successfully very well. The main step in PTMC is septal puncture, and the main step.
Can you connect to Professor Tariq Abbas meanwhile?
Thank you very much. Thank you very much, Mr. Tahir, for having such a nice case in the morning, and must congratulate Pakistan Society of Interventional Cardiology for starting these kind of series, that our centers should present their skills and expertise to all our people, especially the younger lot. This is a complex procedure definitely, and Vidula has done excellently and explained each and every steps very nicely. One thing I would add that the operator should do the echocardiography before starting the procedure. And not only the valve, we must know about all other things like pulmonary hypertension, thickening of the septum, the LA and RA size. And after that, he can plan his puncture site and he can plan all other procedures. And he should avoid going fast because at any stage you can create the complication. And the right heart, people are not doing now the right heart catheterization. When we were trained, we were doing first the right heart catheterization pre and post to know that what is happening on the right side, and the criteria for the success is should be defined and should be elaborated very well. Thank you very much.
Hear us? Can we switch to General Nasir Samor for his comments?
Can you listen to me, sir? Can you hear me?
Yes, we can hear you.
First of all, I thank you all for inviting me as a panelist, and I must congratulate the entire team led by Professor Tahir Sagir and Professor Naveedullah Khan, and for demonstrating an excellent PTMC case. And I think it was very immaculately done. All the steps, even I think the discussion before the procedure and then the complications, I think everything was covered very well. And even he demonstrated the reduction, the RV pressures and all the improvements which were there immediately. I think it was a great case and a lot of learning for all of us and all our juniors. And a few things, very few things, like for example, at the entry point from the skin, once you are taking the balloon in, maybe you need to prepare the site valve for the, to avoid any resistance for the entry, and then you maybe need to make it a bit through the angle of say 45 degrees. And similarly, one can, while preparing the balloon preparation of the balloon is going on, one can leave the dilator in the septum and it take it for some time, and then that can automatically dilate the septum for the appropriate and easy entry of the balloon into the LA. With that, I end my comments and thank you very much for an excellent case.
Thank you, General Nasir, for your comments and excellent guidance about the things that reduce the complication. I would now like to ask Ahmed Noman if he is connected to have his comments. Dr. Ahmed Noman. Can you switch to the screen? You can see at the start of procedure, we did the LV angiogram. There was no MR with preserved systolic function. Now we repeated the LV angiogram, and it again shows there is no evidence of any MR and the LV is preserved. If no further comments, then we can now end this session of PTMC live from NICVD Karachi. Thank you all for attending and encouraging the team at NICVD.